I'll start sharing my screen. So let me, the virtual world.
Yes. Yeah,
It's so
please go ahead
fun.
and take it away, Melinda.
Be careful for what you wish for. Okay, can you guys see my PowerPoint?
I can.
Woohoo! Okay, I just want for the record, I did that. I hit the sharing. You guys, first of all, I have to say thank you so much for allowing me to come and talk to you guys. And also, I am truly living proof that reaching out beyond bedside is the best thing you can do. Obviously, you know about your fabulous mentor program, if that's still going. COVID has knocked out so many valuable things. And Tammy was my mentor years ago, and we still are incredibly close. And the reason I stayed in nursing was because of my mentor. And so all these extracurricular things that you guys are doing is absolutely profession saving. And I can't say that enough. So what I did my doctoral studies on, and I've always had a huge passion for this, is moral courage. So moral distress to moral courage. I came up with this mainly for my doctoral program. And then I realized that there's a lot of information on moral distress, but not moral courage. I mean, we could talk about moral distress until we're blue in the face. But how do you go from moral distress to moral courage is what I kind of did a deep dive in. And I put together a program implementation, which quickly got squashed because of COVID. I had a fantastic, I was so excited for all the people that were going to work with me through the residency programs. Starting last March, actually February and March, I had probably 75 volunteers. And then I was so excited. And then I had more lined up. And then COVID hit, and I ended the year with an N, which means the amount of people I had in the study for 5. it was crazy. So anyway, I was able to get through it due to University of San Francisco. So I'm going to go ahead and start now. And please, anybody, either put your hand up or write a note, interrupt me if you have questions. We can talk about it later, but I love feedback. And if you have a question about anything, I'm not going to spend a lot of time on the slides. I only have like 10 or 12 slides for you guys. So. Okay, obviously, when we talk about moral distress, like I said, it covers everything under the sun, especially in nursing. I mean, who is not exhibiting moral distress right now? We're talking, you're dealing with it with your family outside of work. Okay, then you're dealing with it. Am I going to get the vaccine? Is it going to kill me? Am I going to have a horrible reaction? Does it really work? And all the family questions, I'm sure I'm not alone, which I'm sure you've been inundated with family members. How do I get the vaccine? And they want the inside scoop. Well, there is none. So that's distressing. And then you come to work, which is always so relaxing, isn't it? It's like everything you could possibly want. Shangri-La at Swedish. And basically, moral distress, an emotional state that arises when you are challenged ethically, when you are challenged emotionally, when you are challenged physically. And all these things can happen at work. Moral distress can come about when you want to differ from the policies and procedures. And I know what you deal with a lot in ICU, especially ICU, IMCU, is you have a very good relationship with your physicians, and that's a saving grace. The problem is, I think where you can get a lot of moral distress is, let's say the physician orders something that you think is just out in left field. Do you feel comfortable talking to that physician, LIP, ARNP, about changing course of action? Do you really think that that's a viable solution? That can create moral distress. And I think one of the biggest ones that people talk about it, people whisper about it, people text about it, is hostile work environments, from management to administration to bedside nursing to CNAs to physicians. Hostile work environments are really difficult to deal with. One thing, another reason I got into this was an absolutely staggering national statistic was 27% of all new graduate nurses leave the profession in the first year. Can you imagine? Okay, think back to all the school that you did. And then God forbid we had to study for the NCLEX, right? And that about put me over the edge, let alone everything else you've gone through and sacrifice and you're broke and all this. And then 27% nationally leave for whatever. So you've just spent 2 to 4 years coming up with this profession, which you thought was the end all, and boom. And then 17% of active bedside nurses experience leaving the bedside due to moral distress. And that is not good, obviously. These aren't exactly earth-shattering things that you don't know, but I think some of the statistics, when you say the statistics, it really hits home. And it's scary because the nurses coming in, I can say it since I'm one of the oldest people on the screen here, is these are the nurses that are going to take care of me. Am I going to want someone that's so burnt out that they can't see straight working on me? The ramifications are absolutely absurd. They're physical, they are emotional, all that kind of stuff. And when you go from moral, you have to go past moral distress. And how do you build moral courage? Anyone who saw this presentation a couple years ago in ICU with Tammy and I use this example, and the thing is just amazing to me. This was in 2014, and it's so pertinent to the days, to now. And I'm not going to read all this to you. You can read this if you'd like. I found it on a TED Talk, and Damon Davis is an artist that when Michael Brown was killed in Missouri in Ferguson in 2014, he was very compelled to go to Ferguson, Missouri, and speak. And he overcame his fear of ramifications. What can happen to him? He's a man of color. Is he going to lose his job? Is he going to get beat up? Is he going to get anything under the sun? But he was so compelled to state his mind and to create a better environment for him and everybody in his circle that he went. And I think the most powerful statement that he presented when I watched his TED Talk was that last one that I embolded was, just like fear, courage is contagious. It doesn't have to be violent. It doesn't have to be any of that. It's you speak. And if you have actions that others want to follow, boom, you've just presented a very strong case and successful in what you were trying to do. So always remember, courage is contagious. Happiness is contagious. And I don't want to sound like I'm a soapbox thinking that everything is, rainbows and unicorns. It's not. It's hard. It's hard to be courageous. It's hard to put your thoughts out there, especially today. What is PC? What is politically correct in today's environment? I'm not even sure. So what is moral courage? It's a highly valued element that people look for. It's definitely a virtue in nursing and an element of human morality and acknowledged in nursing. It involves standing up for your values, ethics, beliefs. And when you are willing to step forward for that, just like the artist I was talking about, you may risk your reputation, you may have anxiety, and you also, if you overcome the thought of having repercussions and threatening your employment or hostile environment, then that is considered moral courage. You are standing up for what you believe is right, whatever that case is. It could be patient care, it could be staffing, it could be with family members. It's not just isolated to work. The ramifications is a very tough one to overcome. And that's why further in this presentation, I talk about communication. All of us have dealt with repercussions from work. I don't care if you say it's never happened. There's always some of the underlying discussions that can really disrupt a unit and disrupt a hospital. It's not just unit oriented, it's everywhere. It's in management, it's at bedside, it's in administration, it's everywhere. And it's something that we have to overcome to make the environment better. So how do you develop this? How do you develop moral courage without just throwing yourself out there? There's so much, when you think about it, one of the best ways to develop moral courage among yourself is how you respond and responding appropriately to moral dilemmas. So let's say a physician or LIP, in a case where you feel like you've had a patient for a few days, and let's say it's futile care, and all of a sudden you have a new provider that comes on and wants to schedule an MRI, a lumbar puncture, a CAT scan, everything under the sun, right? And you're pretty much seeing the writing on the wall. Obviously, that's going to create distress in you. And do you have the ability to decatastrophize that? And what that means is make it not such a huge thing. And I know it's a huge thing when we're dealing with death and dying, but decatastrophizing it and just make it into that particular instance, that situation, okay? Not taking it personal, okay? And being able to communicate with that LIP to get your feelings out. They may override you, but wouldn't it be nice to be able to say, hey, why are you ordering all these things? Why is this really going to change the outcome for this individual? Maybe it is. And maybe I just didn't think about that in the time. Thank you. Thank you for your time. And if they say, no, it won't change the outcome, then why do that? Why force this patient to go through all of these studies? And that's just one example. I'm sure you guys could come up with a million others. It's so important as nurses, as caregivers, as mentors, as preceptors, that we come up with our own strategies that work to cultivate moral resilience and moral courage. Because otherwise it's a wonderful profession. And unfortunately, situational basic crap is putting such a black mark on nursing. We are getting pushed to the limits with what we have to do with the amount of tools that we have. Not enough staff, not enough PPE, all that stuff. So I obviously, through about a bazillion articles and talking to a bazillion more people around the country, dealing with how do you build moral courage? Just like so many topics, there is so many topics on what it is. Like if you looked at moral distress, you could find articles to keep you, doesn't this sound tantalizing, keep you busy to read for months and months. Man, I think I'm having a flashback. But so many either studies or research articles don't tell you how you can improve things. Don't tell you, they say it's there. This is factual, it's there. But how do you move past that? How do you have a physical plan? Well, I came across this doctor's work and I reached out to her, and she was just amazing. And we've had wonderful discussions. And she is a lecturer at Harvard Medical School. And she and some colleagues put together this article, and 3 things can help you deal with moral distress and move past that and be able to handle that. The first one, the first level, there's 3 different steps that you can go through. Your first one that anybody goes through whenever there's moral distress is indignation. And a good example is, I'm risking my life. Tell me if you've ever thought about this, because I would think you have. I'm risking my life every day for these patients, talking about COVID and the pandemic on the front lines, and it's unacceptable that I am not being provided enough PPE or adequate PPE. Indignation. I mean, that's a fact. We all went through that in the first few months. There are places in the country are still going through that. They're still in that indignation period. And then you can move past hopefully past that, and you're in resignation. What's resignation? After the initial step, you move on, and then people start to think, or an example would be, I can't fix healthcare in this setting, and I was foolish to even try. Why am I, what? Oh, I didn't know if you had a question, or my walls were talking to me or something. But you can't fix healthcare. Why do you even try, right? Why do we even try? There's nothing in it for me. And I think the key step here is acclimation. This also comes back to the decatastrophizing situations that I just talked about. Acclimation follows these other steps. I apologize in advance if you hear my cats. It's getting close to feeding time, so they're like meowing like crazy, so I apologize. So an example of acclimation is even amid disasters like the COVID, rhythm develops and teams like your ICU unit, of course, they come together and they galvanize as a team and become kind of one as a shared sense of purpose. And if one person does that, it's like being courageous is contagious. If one person says, you know what, let's come together, let's do the best with whatever we have and move forward, because it's all about patient safety. If one person does that, and you get another person and you get another person, you start having the snowball effect. And it is absolutely wonderful for that patient that you're dealing with, but also for your own psyche. So you have come to terms with, okay, we may not have enough PPE, we don't have enough staff, but let's try not to let it affect my next 12 hours, because I kind of want to come out of the day with halfway a good feeling of what I'm doing. Why am I here in healthcare? One of the biggest things that I deal with new resident nurses, and I always love Tammy's introduced me to the same baby nurses. And now baby nurses are of all ages, the early 20s, early 30s, early 60s. I've had everybody come into the world of nursing. And one of the key factors of any relationship is communication. We know that in our relationships, our personal relationships, but you need to bring it to work. And it's kind of funny. Communication is easy, right? Not so much. There are so many facets to it. But when you talk about communication at work, it simply involves giving and receiving information, giving and receiving feedback in a collegial manner. Communication is the foundation of patient safety. And talking about articles and situations, it is one of the key problems to patient safety across the country. I'm sure you all have heard the crazy statistic that on the average, there's like 350 to 400,000 errors in medicine across the country every year. And I would put money on it. Well, actually, it is statistically speaking, it comes down to communication. A real quick example, there was a case, I think it happened back at Vanderbilt. Horrible, long story, but a nurse gave a medication and it was the wrong medication. And it sounded like, oh, I can't even remember. It was a calming agent like Ativan or something. But instead, how this happened, I'm not sure, but instead they gave her Vecuronium. So the patient was down in MRI. Instead of getting a sedation medication, they gave a paralytic. And of course, she died from respiratory depression, right? Of course. That nurse, it finds out, had a nursing student with her. She saw when she pulled out of the Pyxis that it was a wrong medication. She didn't speak up, because she felt the nurse should know better. I'm sure I don't see the name difference. I'm sure she knows something, and I don't want to be embarrassed as a nursing student. What would happen if she would have spoke up? Nothing, except for possibly that person would still be among the living, and that nurse wouldn't have been traumatized. I mean, it was awful. I think it was horrible. Won't even go into all that. But you can see that's an extreme case of lack of communication. So we need to speak up, and it can be done kindly, for goodness sake. I mainly am concerned with new graduate nurses, but this goes along all spectrums, of course. Newly graduated nurses work alongside with seasoned nurses, and that preceptor sets the tone for how that new nurse is going to come into nursing. The perfect example is me and Tammy. My mother died in ICU in my first year of ICU, died up at Providence, and I just wanted to walk away. I was like, this is crap. I don't want to deal with any of this. And because of my mentor, I stuck with it. But she also was such a solid mentor. You can learn how to communicate with your colleagues, learn how to deal with difficult situations, and that can save your career. And it also creates a better sense of self, a better sense of camaraderie when you're able to communicate. We already talked about the safety outcomes. So how do you improve communication? You got to be honest. You got to be consistent. Avoid telling stories, possibly hearsay. Well, I heard that Susan the other day gave a wrong medication. Right there, that's hearsay. Did you see it? Probably not. Did you hear it? Probably not. And you should always ask to be included. And one thing I dealt with for many years in ICU is, if you can see on this little screen, 7% is words. I mean, that's nothing. I can tell you you're absolutely wonderful, but if I say it, yeah, you're okay, you're wonderful. The tone, do you really think that? Probably not. And body language is so important. And this not only goes for collegial communication, but also with your patients. Can you imagine if you walked into your patient's room and your arms are crossed and you're like, oh God, do I have time for this? I have other patients to take care of. But I honestly believe when you have to check yourself before you communicate, always think to yourself, check your own emotions, because that comes out in your tone. I think one of the strongest examples are bedside report. When you come on and you're getting bedside report, that nurse that you're talking to is kind of setting the tone for your day. Sure, it may have been a crazy night or day. They didn't get to cleaning their rooms. They didn't get to some of this other stuff, but nursing is 24/7. It is okay. You know, I can take care of that. But also, if that person giving report is totally snapping and being rude to the person coming on, how does that set your tone for the day? It pretty much sucks. You know, I've talked to Tammy at length about this, and not only does it just suck, but it has affected me personally for years. Some of the communication that happened at report, like it affected me as a nurse. Now, of course, I'm like way past that, but it was very difficult as a new nurse. As a young nurse, let's say you're only been there 2 years, that's still a very young nurse. And if you get just eaten alive by somebody, that leaves scars, emotional scars. And I don't wish that upon anyone. It's that old, nurses eat their young. I would like to say it's completely gone, but we all know it's not. And that's the sad thing. We need to improve our communication. Never assume. That is the biggest thing, because we all know what happens when you assume. Giving constructive feedback or bedside report, there's nothing personal in that. You need to leave the personal aspect out, not personal, and it shouldn't be taken as such. So if you need to correct a nurse, I think I saw you hanging that IV. Can you explain to me why you hung it on the arm where you shouldn't have been? Let's say they had, you put an IV in on the person that had breast cancer on the same side, whatever. You can think of a million scenarios. It's not personal, it's factual. I saw you do this, or you did this. Can you explain to me why? And it shouldn't be taken personal. We as nurses take on so much that it's just, we're capped out. We try to save the world every single day. We try to save how things are dealt with, everything. And we need to kind of put that aside. And remember, feedback communication should not be personal, shouldn't linger on. If you ask somebody to change a practice, it should be just left at that. You don't have to mill on it, nothing. You said your piece, you had facts to back it up. It's not hearsay, it's not a story, facts. And just in my program or in my project, I had videos that we put together in the SIM Center, and the residents that were in my project, it was fascinating because I put together some videos of a really poor bedside report and then a really good bedside report. And it was interesting how these brand new nurses, all under a year still, could relate to every single, from the bad video to the good video, and it sets your tone. Like a good example I had in the video was A nurse comes on, a resident or a new nurse comes on, is taking report. Okay, let's go. I'll meet you at the bedside. Oh, I don't want to do bedside report. I'm tired. It's been a rough night. Let's just sit here at the nurse's station, right? We can look at the computer. Well, is that the right way? No. Is that evidence-based practice? No. The reason I say that, as a manager on 10 East, due to bedside reporting, we found a few grave errors that could have been sentinel events. And so when a person, especially in IMCU or ICU, you have no less than, 50 IVs going and chest tubes and NG tubes, G tubes, J tubes, every A tube, every tube under the sun. And you need to check those. What if one came out and the person's sedated? They don't know. And that's why it's so important. You have to have that communication. And I'm just using bedside checkoff as an example, because that's a new nurse, and that could be very disarming if they go in to do their assessment and the nurse that left didn't check with them, and the nurse is left for the day, and all of a sudden their chest tube is out or their NG is backed up or something's clogged. It's harsh. It's really difficult to kind of start your day with that kind of stuff. So it's just to restore integrity in the profession, integrity with communication. There are so many quotes coming out right now, and there's something I have on my email, just the little byline, and it's like, with everything you can do in the world, or with everything you can become in the world, be kind. And it sounds kind of corny, but when you think about it, there's not enough kindness. And the world is what we make it. It's what we make it. That's the most important word. We, our what we have control over. We don't have control over everybody else's emotions. We don't have control over what patients are going to come in with what diagnoses or what is the latest pandemic. I seem to have missed the book on how to deal with pandemics. And we can't control so much, but we can control what we do and try to control our own little world. And if we can make it better. So it's what we make it. And if you can improve upon that, you have done it. You have been successful as a nurse. You have been successful in life. Now it's like my favorite picture of all time. I love this. If we had more lions, and it would be amazing. See yourself, it keeps coming. It was 2020, year of the nurse, the most trusted profession, nurses. I think we only fell off in 9/11, and that was firefighters and police officers, but we still always rank right up there. And I'm sure with our lovely pandemic, we're going to be right back at top spot. We need to live up to that, and we can make it better in our own little world. That's all you have to worry about. So feedback, talk. Am I back to the screen? Yeah, I think. I hope.
Yeah.
Okay. So could you relate to any of that?
Thank you, doctor.
Well, thank you.
Yeah.
That sounds so weird, Marcus. It sounds so weird.
You're welcome. Yeah, I mean, I can relate to, like, oh, sorry, that's recorded, whatever. I can relate to all of that. Yeah, all of that. Every piece of the sort of moral, the compassion fatigue and the challenges that we've been through this year, and being in the middle of, I do a lot of precepting, and trying not to pass that on, and trying to still do all of the things that I know are best practice, and yet are really hard to do. I mean, bedside report's a big part of that. It's just one example of good habit, but it's something that I and most everybody in the unit have been really bad about for a while, and it's hard to push back against the weight of an entire unit that does not do something. It
Absolutely.
does not have that piece of culture, And yet I know that it's like every time I do it, I'm like, yeah, boy, that makes actually a big difference. Like I feel like I have been in the patient's room. I've seen them. I don't feel like I need to rush back in there later.
Absolutely.
Know that their fluids are not going to run out. I mean, it makes a big difference. But
and another thing that I think is so hard, but we have to overcome it some way, because Marcus, you just hit the nail on the head. That is perfect. It does make the day go smoother. It does make a transition of care so much smoother. But I also realize I will never not be a bedside nurse at heart. I realize you get there at 7 and boom, you have how much time, right? About 5 seconds to do that bedside report. And you may have to adjust your practice a little bit. It's really, you come in, you start talking to people, you say hi to people, and then pretty much it's 7:20, and then you get yelled at if you get out late. You get yelled at if other people get out late. It's like this ongoing circle. But if we can do that, it just makes the whole system run more smoothly. And we do catch those errors. Like you said, running out of fluids can be absolutely critical for someone. And I'm singing to the choir. You guys know much better. I'm just rusty. So I think it's tough, but you're right. Thank you, Marcus. It was spot on.
I'm just going to take a moment and say, thank you, Melinda. This is everything that you shared is so helpful. And I mean, it hit home with me personally for a lot of different things. I am going to pause the recording soon. And I just want to be conscious of everyone's time.
Absolutely.
If you need to go, please feel free to sign off. You don't even need to say bye if you're not comfortable doing that, but just know that we appreciate you all being here. So thank you so much.